welcome. My name is Rebecca Dolick, and I'm excited to welcome you all to our joint webinar event today, brought to you by Minnesota HIMSS chapter and the Medical Alley Association on the new interoperability rules, what'll work, what won't, and what patients can expect. We will be recording this event and making this available for future viewing on the Minnesota HIMSS website. If you would like to be a speaker or a sponsor for a future webinar event, please reach out to us on our webpage at mn.himsschapter.org. We will do a Q&A at the end of the session. Please type any questions you have for our panelists in the question section of GoToWebinar. At this time, I will turn it over to Bobby Patrick with Medical Alley Association. Bobby?
Great. Thanks, Rebecca. I'm Bobby Patrick, and I'm the Vice President of Strategic Growth and Policy for the Medical Alley Association. On behalf of the Medical Alley Association, thank you for sharing part of your day with us today. Our vision is to elevate Medical Alley as a global epicenter of health innovation and care. Medical Alley is home to the world's largest health technology cluster, the world's #1 hospital, and a thriving hub of both biotechnology and digital health. Our members greatly value the unique opportunity that the Medical Alley Association provides, the ability to connect with and learn from other leaders from all sectors of healthcare and continue innovating in the delivery of healthcare to drive more value, improved outcomes, and lower costs for patients. We're excited to partner with the Minnesota chapter of HIMSS on today's event. The new interoperability and data sharing rules are going to have a significant impact on healthcare. Today's speakers and panelists will have unparalleled insight and expertise into this critical issue, and we are grateful for their willingness to share those with us today. And with that, let me introduce today's first speaker and moderator, Mark Scrimshire. As a CMS Blue Button innovator and entrepreneur in residence, Mark architected and built the Blue Button 2.0 API for Medicare. Mark is a Chief Interoperability Officer focused on promoting the adoption of standards-based interoperability and across healthcare. Mark is active in the HL7 community and is author of the HL7 Da Vinci Payer Data Exchange Implementation Guide. He brings his passion for improving consumers' access to their health information and his experience delivering solutions for payers and global companies, such from 3M to New Wave. Mark, I'll turn it over to you.
Thanks, Bobby. It's great to be here. Thanks for inviting me. I'm also really pleased to have a fantastic group of panelists, so I hope we have a spirited discussion. Let me briefly introduce them here, and then I'll get into actually trying to set a little bit of context, and maybe we can have a really spirited discussion as we go on through the session today. First, let me introduce Klaus Jensen. Klaus is the Chief Digital Officer and Head of Technology for Memorial Sloan Kettering's Cancer Center. As the Chief Digital Officer and Head of Technology, he oversees integration of data and technology resources and develops the data and digital platforms that enable Memorial Sloan Kettering to meet the critical patient care and research objectives. He also directs the operations of information systems, health informatics, and data products, as well as other core components of Memorial Sloan Kettering's information technology ecosystem. He works closely with other leaders at MSK to create and optimize solutions that benefit patients, researchers, clinicians, and administrators. He's obviously a transformational change agent and has a great track record. I'm really pleased to have him here today, so thanks, Klaus. Also, we have Kevin McDonald from the Wisconsin Health Information Organization, or WIO. Kevin is a Director of Business Development and Partnerships with WIO, and he serves as a data evangelist and business partner to healthcare professionals that are dedicated to improving the health, wellness, and overall well-being of the people of Wisconsin. Additionally, he consults, advises, and collaborates with various stakeholders to improve operational effectiveness, reduce variation in care, increase opportunities to use evidence-based practice, and innovate in a myriad of ways with help from the WIO. Claims data is used to provide or oversee high-quality care at lower costs to capitalize on more opportunities, and to successfully engage in value-based contracts and to better understand the needs of healthcare consumers and communities. So welcome, Kevin. And last but not least, Bill Jordan. Bill comes to us from Blue Cross Blue Shield of Minnesota. Bill's a marketing, product, and digital strategist. He has cross-industry experience in delivering innovative solutions to business opportunities. As a long-time consumer advocate and pioneer in the digital space, he's worked with some of the earliest interactive adopters to create or enhance business and product engagement at the crossroads of technology and consumer experience. So as you see, I think we've got people representing some of the key players, both in the Minnesota space and nationally. And it's really interesting as we really go into a new chapter with the CMS Interoperability and Patient Access Rule. So we talk, the title of the session is, you know, what will work, what won't, and what can patients expect? So let me try and give a little bit of context. So let's go on to the next slide. Enough about me and my 5 years at CMS. So Rebecca, if you can advance the slide. Firstly, I spend a fair bit of time talking to payers today, apologizing. And that's because I literally was the first person on what became the Blue Button 2 project. That was kicked off way back in 2015. If we go to the next slide, some of you, if you've listened to CMS talk about the interoperability rule, they lay out this timeline from the past, and you'll see back in March 2018, Blue Button 2 was launched. I spent the last 2 years really evangelizing and promoting the adoption of Blue Button 2, but the important thing was the release of the notice for proposed rulemaking in 2019 that was then finalized this year in 2020. But if you look at this diagram, you'll see that there are various things happening. We're going to talk about the patient access API and some of the open APIs that CMS point to in that landmark rule. But you'll notice with the diagram, it doesn't end at a wall. It ends with an arrow. It points things that are going to go on. So this is very clearly indicating from CMS that this is not an end point in compliance with this rule. This is a starting point. It's going to be an evolving road. And so we need to think as stakeholders how we're really going to step up and really change the way that healthcare is delivered by making use of interoperability and the ability to share data. Let's go on to the next slide. So what I really want to do here is just cover at a very high level. And in fact, if you go to the Onyx Health site and find our interoperability insights, you will actually see in the blog an article that we posted on really a summation of the CMS rule. But the key thing is that the implementation is set for January 2021 for the patient access API. That's the claims and encounter and the clinical data. It also requires that a provider and pharmacy directory and a drug formulary API are made available as well at the same time. The reason we've got Jan and July there is that the deadline is still January, but the date for penalties being applied is currently set to July. And we're currently not sure whether CMS is going to give another extension given the current pandemic situation. The real change, though, potentially happens in 2022 when payer-to-payer data exchange happens, when consumers will be able to say, go get my data from my prior payer. And that will really, I think, ramp up the use of data across the industry, particularly in the payer market. And then there are other things coming along in 2022 around improving benefit coordination between Medicare and Medicaid. Let's go on to the next slide. So I just want to try and give a very high-level view of what CMS is asking primarily the payers to do. And it'll be interesting to, as we go into the panel session, to see what the knock-on impacts are seen by other stakeholders like the provider community. So the Patient Access API covers claims, encounter, and clinical data. So there is the Karen Blue Button implementation guide from HL7 that is a FHIR implementation guide. That's Fast Healthcare Interoperability Resource Specification. As people say, the hottest thing in healthcare right now. That is really based on the work that we did at CMS in defining an interface specification for releasing claims information. So the Karen Alliance has basically upgraded that to the latest version of FHIR and is really handling the claims and encounter data in a standardized format. But the rule talks about US CDI, which is really in FHIR terms is US core. And I've been involved on the Payer Data Exchange or PDEX implementation guide, really providing a wraparound to US core to make that clinical data available via the Patient Access API. Then in the open API space is this need for a provider and pharmacy directory, and that's there in the rule. And that really is about the shopping experience for consumers. Typically, when you move from one plan to another, what do you want to know? You want to know, is my doctor in your network, for example? Or are the types of treatments, the types of providers, are they available as in-network services? And then the other side of that is, I'm taking medications. How do you classify my drugs? Are they generics and they're cheap? Are they expensive? That's defined by the formulary. Now that's an area we're still waiting on clarification from CMS. Originally in the proposed rule, they said it was going to be an open API. In the actual final rule, they said it's part of the Patient Access API. CMS are currently saying, well, you could do both. So we're just waiting for some formalization there about how that will play out. But the actual format of the implementation is pretty well set. Let's go on to the next slide. So one of the things I want to talk about, just to give you context, there's a number of elements of the CMS rule and the Patient Access API requirement that is really virgin territory for many health plans. There's this issue, what we learned from building the CMS Blue Button for 53 million beneficiaries is really the FHIR API is the easy part. You need to be able to get data in from all of your different legacy systems to make it available in FHIR format. CMS expects you to test the APIs to see that they are compliant. You need to be able to integrate the member, because unless they can authenticate, they can't authorize. And then you're going to have to basically make available an app marketplace so that they can choose apps. You're going to be able to have to recruit developers, give them documentation so they understand how your API works, and then finally actually approve them so that they get credentials to be able to interact with your API. And speaking personally with what we've done at Onyx, this is really where we built this Sapphire as a secure architecture with FHIR to really provide all of these as a complete solution. Let's go on to the next slide. So these are the things that the health plans are dealing with, but with the Patient Access API, as I indicated, these steps to consumer-directed exchange really have 3 steps to it. You need to have an identity, because without an identity, you cannot authenticate with the health plan typically in this instance. So you really want to be able to use maybe your member portal credentials to be able to say, this is me. Once you've done that, you can then authorize sharing. You, as per the rule, which is really all or nothing, you can say, I want to share my data with this application because it benefits me. And that is really the step. So once you give an authorization, you give a token to the third-party app, and it can now access your data on your behalf. So the app only gets access to your data with that set of credentials. If they want to get access to other people's data, they've got to get them to authenticate and authorize the sharing. So this is the key thing at the center of the rule, is this consumer-directed exchange of their data. And it's really the precursor to a wider exchange of data across the industry. Let's go on to the next slide. So the key thing I wanted to highlight really from the rule, as I read the CMS rule, is they talk about data that is maintained for a member. And that's important because that sets the boundaries of what is going to be exported by the health plan. Let's go on to the next slide and put that into context. So when you look at the rule, what is happening is providers and other services that are being provided to the health plan on behalf of members, a lot of data flows in. It can be in the form of claims, it can be in the form of clinical data. The payers take all of that data. Now, what CMS is basically saying is about maintained clinical data is regardless of the way it came in, is it coming in on a claim or is it coming in some sort of clinical record like a CCDA, but does it now fall into this class of data elements that is defined by US CDI, basically the core clinical data set? If it does, and you are maintaining that information for a member, you are going to have to release that basically through the clinical API. So the claims API, the Karen Blue button, will release claims data to consumers. When it comes to 2022 and payer-to-payer exchange, it's only the clinical data that is going to get exchanged. So when you sign up with a new plan, you would be able to give your coverage information to your new plan and say, go get my data from the prior plan. They would be releasing basically the US core set of resources that is your health record to the new payer. And that is what can potentially be incorporated into your record with the new health plan. But so what we will see from a third-party application developer perspective, they may take data from that claims API, the blue button API. They may choose to take data from the clinical APIs, the basically US core and PDEX. And they may also take data from the open APIs, such as the provider directory, which would have far more information about a provider and an organization. So this is really the heart of the issue that payers are currently grappling with, is beyond just the claims information, what clinical information do I actually maintain for my members? I've now got to get that mapped into FHIR and release it. So there I've tried to give a very quick, very high level coverage of the issues of what is being covered in the CMS interoperability and patient access rule. But let's go on and hear from some of our other panelists. So Kevin, I think now it's time to hand over to you, and I'd like you to maybe give your perspective on this interpretation of the CMS rule.
Sure. If you could advance to the next slide. Yeah, thank you so much. It's so great. I'm an honor to be part of this HIMSS Minnesota event. What I'm going to do is take you on a journey that I've been on in the last 10 months working with the 15 or so health plans, our data contributors that we work very closely with at the WIO. Back in May of 2019, we did some market research to find out what was on the minds of our payers relative to the CMS final rule. And we learned quite a bit of things, and one of the things we captured was that they were very concerned about how to comply. They were concerned about costs, and also they were really wondering about the timeline and how long it would take them. And they had a lot of concerns also about their internal resources, about would they have enough availability? Would they be able to do this on their own? Also, they really talked a lot about member data privacy. That was a really big concern with the new rule. It was the rules and the specs were not yet frozen, so They had some concerns on how that was going to play out, whether they built a solution themselves or if they worked with a provider to come in and a vendor to build one for them or provide one in a cloud environment. And the other thing that I learned from talking to peers throughout Wisconsin and even outside of Wisconsin was that they were very skeptical of the value. They thought, well, will these requirements drive up costs without comparable cost reduction through consumerism? And they really doubted whether or not consumers were capable of using the information, at least not at first. But on the other hand, they did see that there was going to be some great benefits, some standardization of data, which they saw a lot of promise in. So that was something that they saw as a real positive there. So if you could go on, move to the next slide. So we set out to be potentially offer a statewide solution to partner up with our data contributors, and this is what we basically learned. We learned that the national payers weren't interested, that they were going to delegate the responsibility of understanding the final rule and the requirements and developing a solution throughout the United States or their plans. Next, if you advance. But on the other hand, we heard from the regional payers, the ones that were predominantly in Wisconsin, that there was a really big opportunity for us to partner with them and engage and mobilize to help them out with the solution. But ultimately, what they said to us is we had to make sure that the WEO and the solution that we proposed, had all the right capabilities and the know-how in order to do it really effectively. So if you could move to the next slide, please. So what I did was I did some gap analysis. I figured out what were the capabilities that we had at the WEO and with our data management system partners with Symphony Care, which is also headquartered out of Madison, Wisconsin. I did the gap analysis and figured out what we were missing. And when I did the analysis, I learned that even though we had quite a bit of capabilities on data and transformation, data mapping, things like that, we didn't have any background in FHIR server implementation. So that was something that I was looking for out in the marketplace to help our data contributors to create a really rock solid solution. And then I looked at all the myriad of the specs, the rules, the implementation guides, the use cases. I saw that we had a knowledge gap there and we needed to align ourselves with some experts that were really strong in that capacity. So I noted that as something that we wanted to do. And then I also thought, data privacy, this is a big concern that was outlined by the data contributors. So I had to make sure that we had a really great answer for how we're going to keep the member data very secure and adhere to any privacy needs that the health plans had or the rule required. And then another thing that I thought was really critical was, developer recruitment. You can build a solution, but you want to make sure that the app developers come to make great use out of the information on behalf of the consumers. I saw a gap for us in experience with bulk FHIR. I knew that was on the horizon, getting very strong, and that was important to whatever solution we offered. And then API security too was another critical piece that I knew that the payers would really care about. So understanding of having lessons learned, someone who had been there before could come with some really strong experience right at the outset. That was a really big thing. Someone who had the inside track on the knowledge, who worked hand in hand with folks like the Da Vinci Project or the Karen Alliance and CMS itself. We were really looking to align ourselves with an organization that would bring that those skills and knowledge to our payers. So that's kind of a summary of what I did, and it was very helpful as I worked with our payer partners to put together a solution. So if you could just advance to the next slide, please. So when I got into this process, one thing I learned when I worked at GE Healthcare for 8 years is you don't know what you don't know. And the more that I peeled back the onion, the more that I understood about the requirements and the rules, the implementation guides, the strategy that could be developed by doing the right smart things with technology, the more I knew I didn't know. And neither did the payers that I was trying to help. So that was a really a big lesson that I learned, that this is a very complex problem with a lot of different solutions, and there's going to be a lot of consequences, both positive and negative, depending on what type of solution you go with. So if you could move to the next slide. Could you? There we go. But one thing that our health plans were really clear about is that they said, how are we going to get a return on our investment? We need this investment to do more than simply meet requirements. So that was something that I was really laser focused on. Learned was that just getting the requirements done for the rule, that was one thing, but how do you get the value beyond that? And in essence, this schematic here, this simple high-level schematic, kind of explains with what I learned and what I try to do working with our payers. The first thing is that you got to look at the new member data is being received by a native FHIR solution. This is critical. It's about catching the data. You can send the data out into these apps and all of that, but the real value is going to come when you receive the data and put it into a format where you can do a lot of analysis, do math on it, where you can have it interoperate with your internal health plan and operational systems. And the net is when you have this type of system in place, you can do some things that are going to be really fruitful. You can do things like reduce chart chasing. You can make sure that your members are getting into the right services right away when they come onto your health plan. You can eliminate redundant services, and that's something as healthcare consumers we all don't want, and it's inefficient. And another thing is you're going to be able to impact member experience, because when you join a new plan, you're going to feel like the members, that is, they're going to feel like that you know who they are and what their healthcare needs and that you care. So I think that's a really big deal. And lastly, I think doing the smarter operational planning, when you can do the math and understand your population and their health history and their healthcare needs, I think that's also very, very important. So if you could advance to the next slide. So if there's one thing I want you to know is that there's pitching and catching. And the real value for health plans is the ability to catch the data and use the data smart and to really have an impact on the bottom line, both clinically and also with costs. That's how you're going to get the return out of your investment if you're a payer. You can go to the next slide. Thank you very much. I look forward to your questions and being part of the panel. Thank you so much.
Kevin, thanks for that. I think that's a really important point, pitching and catching with all the plans really across the country, publishing information. It really is, there's going to be more data out there. Do your members trust you to share their information? That's really going to be the key thing. So now let's go on to Klaus, and you come from the provider perspective, and the provider-patient relationship is one of the strongest in healthcare, and so I'm really looking forward to what you have to tell us in the impacts of this rule to the provider community. Over to you, Klaus.
Thank you. So it's quite interesting because everybody says this is a rule for payers, and in some ways, as it's been laid out, that's kind of where it starts. But I want to spend a few minutes just talking about the patient perspective, what patients actually expect, and what that means in terms of why interoperability is important. Next slide, please. One of the things we're seeing very clearly, and it's really hammered home throughout this last 7 months we all had to deal with, is that increasingly health consumers, certainly our patients, are much more willing to share and engage. I mean, it used to be that, yeah, this is a little dangerous, I don't want anyone to have my information, but the growing up generations, it's not just my kids, it's even me, and to some degree generations before mine, we've become so comfortable with digital exchanges that we'll give you our information, we just want something in return. That value exchange equation has not quite gotten to healthcare yet. Healthcare is still very much in the data. It's siloed, it's sitting wherever it was. If I want to do anything, I have to go to a physical place, and that all blew up as you weren't able to go to physical places anymore. So the last 7 months have been fascinating in terms of what the lack of interoperability actually does to the patient experience. Next slide. The fact of the matter is, you want the health consumer and your patients for sure to feel that you're local and this is a trusted relationship. And we are partners on the journey towards health. And we have all been trained outside healthcare to expect these three things. We expect the experience to be coordinated. In healthcare, that means if I went to one doctor, why aren't you talking? And it certainly happens across healthcare provider systems, but even sometimes happens within different locations in the same provider system. I don't know whether you've ever tried to go to one of the big sort of multi-site kinds of environments, and it's not always connected. If you're lucky, they've implemented an electronic medical record that has most of it, but the system context that gets lost beyond that. They certainly want you to know about them and give you advice and help them achieve their goals, which requires synthesizing everything we know. And why can't you give me access to everything by the touch of a button? I mean, that should be possible. I mean, technology has progressed, right? So we know how to integrate. These are very reasonable expectations. And there are expectations that in any other industry but healthcare, we take for granted. But if you think about it, if you have siloed data, that's bad enough because you can actually not really get at it. Let's say we could solve that problem. One of the big differences between finance and healthcare, I started my career in finance, it's many years ago. The thing about finance is interchanges are very well defined and have been for 50 years. There's no meaningful financial information that's not codified in some kind of structured transaction. What do you do with a doctor's note? That's free text that somebody wrote in. How do you interpret that? Do we have a standard for, what does it mean? What do you mean that I'm stage 3? Like, this other doctor said I'm stage 2, and I got a second opinion and they said something different. So it's not just a tactical definition of content. It is for much of the interesting healthcare information, certainly from a patient and provider perspective, as much about the meaning of the data. The meaning of the data is a lot more difficult to interoperate and transfer than the sheer bits and bytes of the payload. If you look at the evolution of FHIR, it started with the stuff that's well defined. I mean, a claim is a claim is a claim. There's an ICD-10 code, there are CPT codes. It was clear who the provider ID was. We know who the member was. This is the kind of stuff that you can codify as a transaction. And it's kind of like other industries, you can standardize that and you can change it. That's a great start. But let's take a look at what the rule actually says for providers. Next slide. Because now it gets interesting when I get this slide. This is not something that's been talked a whole lot about, but I went digging just to see what actually was out there in terms of what was published. And there's not the same kind of rigorous, timeline and deadline about this, but this is actually wrapped from the site that publishes the rule. Admission, discharge, and transfer event notifications. The conditions of participation is to require hospitals to send electronic patient event notifications of a patient's admission, discharge, and/or transfer to another healthcare facility. What's interesting is what it only says is you got to tell them that something happened. It says nothing about how do you tell whom, given that we don't have a fabric that allows different provider systems to even talk in the first place. It also doesn't say what do you send with it. The notification itself isn't actually useful. If you look at the last part, this will improve care coordination by allowing a receiving provider, facility, or practitioner to reach out to the patient and deliver appropriate follow-up care in a timely manner. You can't actually do that without getting more than the event notification. That's not enough. If you're talking about connected care, you need to understand what was the plan. This person was discharged. What's supposed to happen now? And that's still staying locked up in your EMRs. We have seen different players in the industry create the physical connectivity, be that the EMR providers or some of the other technology vendors out there. I certainly have a team myself that is capable of standing up a physical connection. What we haven't cracked the code on is a platform that allows me to understand what it actually meant. And to implement the intent of this part of the rule, we have to understand not just the syntax, but the semantics, because it's going to have to be read by humans, understood by humans, and those humans are by definition not necessarily perfect in interpreting the written word. So what we really need, and we don't have it, not even close, next slide, is a platform. We need a platform from a patient perspective that doesn't just do claims and it doesn't just do event notifications. What it actually does give me a meaningful connected journey as a participant in the healthcare ecosystem. And what good, in my opinion, looks like is I have this little mosaic kind of acronym. We have to build something that's meaningful, so we have to understand why. My definition of why is it's all about connected care. Yes, there are lots of other reasons, but it really is about connected care, and that requires more than we have. It has to be open, so if you have data, it has to be accessible. It has to be simple, rationalized, easy to navigate. Even if I did the first two, we built this platform and said it's going to be open, it's going to be connected. If I can't crack the code on a simple way of rendering information that I need to transfer across the ecosystem, I haven't solved the problem. Things are going to change, so whatever we build has to be adaptable. What is holding back finance, again, going back to one of my earlier industries, right now is that while the standards are great, they're not necessarily adaptable to when things are changing. It has to be innovative because we can't stand still. And healthcare is a field where we've done a lot of innovation over the last couple of 100 years. And everyone is going to do it a little differently. So we see lots of healthcare systems out there that are configurable. How do you marry all of this? It requires a whole lot of rigor, thought, and I don't actually think standards are enough. I think we need to start architecting healthcare systems differently and having a shared definition of what does good actually look like, so we can get back to providing a connected and integrated care experience. But the people are all here to help, right? Whether we are a PBM or health insurance company or retail pharmacy or provider-side organization. And by the way, I would work for all four, so I've seen this problem from all the angles. The real reason that we try to share data and connect things is to help the people out there that are either trying to get back to health or just want to stay healthy. That was my last slide.
Okay.
I do think it's time to turn some of that vision into action. That's my personal opinion.
So thanks for that, Klaus. Really insightful. And there are some fascinating things going on in the space as CMS interprets their own rule. Just thinking about your comment about the semantics of the data, and there's a lot of unstructured data, and maybe we need to just start to get that flowing so that it can in the future be interpreted rather than trying to extract it now when we have an imperfect way of doing that. I want to now really hand over to Bill. Bill, you are a strategist. You've got deep experience in healthcare, and you're right in the heart of one of the big payers certainly in Minnesota, if not across the US. I'd be fascinated on what you're taking away from what's been presented so far and the issues that you're really grappling with as a payer.
Thanks, Mark. So I appreciate the kind words. I've been in the healthcare industry now for about 5 years, so I think I'm just scratching the surface, actually. But I come to it with a strategy background and with a consumer emphasis on that. And so, Klaus, I appreciated how you started your discussion there, talking about it from the consumer level. That's I think that's really important. If you go back to the emphasis on what the rule is really meant to do, and actually I'm going to read something. One of our digital architects was writing about the rule itself. He basically said the government's upset at the healthcare industry for not achieving interoperability on their own, so they're stepping in to force the issue. And this is way oversimplified, but he said the federal government believes if we expose a patient's healthcare data in an interoperable way, that then third parties will come and build tools that allow patients to manage and control their healthcare using their data to formulate better decisions. And if you think about that, that's the gist of the rule itself. And if you go back, that's really the gist of what the ACA was built on. So it's, that the ACA was foundational. This is coming on top of that. Now, from an insurer standpoint, we're in a really interesting place. I cannot tell you how many times I have listened to consumers talk about the various roles that they see in the healthcare industry. And the essence of it is providers are good, insurers are bad. All the insurers do is take in a lot of money. They spend most of it in profits, and they give very little value back. And so our level of trust with the consumer is relatively low. They very highly value what the providers are able to deliver and support. And so I think we work very hard to try and deliver a lot of value, and a lot of that value is derived from data itself. So yeah, we have our hands on a fair amount of data already. Some of it is highly disorganized. Kevin, you spoke to that. It's in silos. We don't necessarily have the skills or the ability yet to bring it all together, and that's obviously what the rule is meant to do. And I was intrigued again, Kevin. You were talking about insurers looking for an ROI on this, and that's really where the ROI is. Now, from an insurer standpoint right now, and having spoken with a number of my peers across the Blue Cross network, most everybody at this point in time is looking at this as short-term. It's a cost. It's something we've got to do right now. I think we all see the long-term benefit of it, but and again, across the entire Blue Cross system, there are varying degrees of, I won't say interest, but I will say desire to really leverage the data that will now be more accessible to them in ways that will actually deliver that ROI. And just realize, I'm speaking as one insurer with one point of view, and I think you'll find a variety of points of view across the entire spectrum. But again, I'm coming at it from the consumer standpoint, and from our standpoint, we can see the value, the long-term value to the consumer in doing this. And the interesting thing is, for us, bringing this data in and having better ways to access it, we had other plans already in motion. So this work is actually already supporting other work that we had in terms of being able to consolidate data and provide better access to it. So from that standpoint, it's great. It's kind of a win-win for us. But I think we're still in the very nascent realm of this, and the strategy so far for us is we have our data scattered across, actually not just in different places within our organization, but actually in 3 different entities that we partner with. So a lot of our challenge is, how do we bring all of that data back in-house and consolidate it in one point? That's what we're fighting for right now. And then over time, there are discussions ongoing about how we'll go about leveraging it to deliver the kind of benefit that that we're all looking for here. So that would be my top line assessment.
Bill, there's some interesting points there. One of the things, I've had similar sorts of conversations with CMS around, they have lots and lots of business partners providing different elements of their business. And this is one of the things I've, spent a lot of time thinking about, is this idea of that not many organizations can have the the resources of, say, a Google, where they can amass all of the information. And I think one of the things that will evolve out of these initial steps is that it'll become about being able to access the information, not necessarily being able to own the information. So is it a case of, have you got to pull the data into one centralized place, or is it you've got the permissions to go and get the data you need when you need it? And again, potentially consumers can play in that role. I think there's some interesting things on the the roadmap that people are looking at in that respect. I some of the things from CMS, my days at CMS, is say the first thing is trust is job one. We are moving to a point where you may say, people say providers are good, payers are bad, but really this situation is, who do you trust to be acting in your best interests? I think this is laying the groundwork for us to move to a scenario where we as consumers will find an entity that we trust. It may be the app in our pocket. It may be providers like Klaus that are giving us service. It's the provider relationship. It may be the payer that's coordinating everything. Who do we trust? And they will deal with the reconciling all this information and taking control of it, because we, I think as consumers, don't care about the information until we have to care about the information. And that's the scenario. We just expect it to be where it needs to be. That's what we've really got to move towards. And so, Bill, to just give you another chance, and please, let's have a conversation, and I will also call out to the audience. You've got the questions box. If you've got questions you want to ask these folks, they have some great insights. Pose those questions, and we are happy to go on past the top of the hour. I know I can hang around and talk all day on this stuff. Bill, what I was going to say is, we said that the rule really focuses around the regulated markets that CMS manages, Medicare Advantage, qualified health plans, and so forth. That's $1 trillion of a $3 to $4 trillion market. There's a lot of commercial entities. What do you think plans are going to do in that? Yes, they're taking this as a cost and they're dealing with these regulated lines of business. Do you see them looking at spreading this same infrastructure across the rest of their lines of business?
I would very easily say yes. I hope so. Now, I mean, and part of that is we ourselves are compelled to demonstrate both the value and the security that can be delivered. And as long as we do that, then I think we're fine. So another example is, right now, we very strongly believe that Apple, as a third-party entity, actually we know they're already poised to be able to be one of these third-party applications to bring all of that information in. So I don't know how much people are going to trust Apple versus an insurer or a provider, but there you are. They already have the platform built. So they're literally waiting for the data to be made available. Are consumers going to trust Apple more than they would a provider? I don't know. But it's incumbent upon each one of us in the field to demonstrate, as I said, to demonstrate both the value and, for those that are concerned about it, the security that is available in exposing all of that data. If we can do that, and it's again, taking the consumer perspective, the consumer's got to see the value in it. If they do, they will go to it. They will follow it. They will engage. They will more than engage. They will embrace it. If they don't see the value, then why would they? They have many other things to do. So I think that's going to be the key, is showing the consumer the value, really demonstrating it.
So I'm going to ask Klaus and then Kevin. So Klaus, as we said, a lot of this CMS rule, other than obviously the ADT initiative, which I think is due to go in November, is really focused around the payers. But what do you see happening, the knock-on impacts for providers with all this that's happening? Do you see it as an opportunity to be able to get more information on your patients? How are you looking at this?
I'd say I think we have to. I mean, if you take an area like New York City, there's 30 to 40 major hospitals, and they're not really connected in the way I talked about. It's interesting that a lot of the dialogue around all this has been around, well, you know, what are the downstream effects for providers? From a provider perspective, the claims are downstream. They're important, but they're downstream from the actual event, and they represent a codification of something that's really aimed at billing and claims adjudication. That's absolutely important. You can learn something from it. Now being on the provider side, and used to work for the other side of the equation, the intangibles up front, all the information around written notes, contextual information, you know, what's your family situation, what's your family history, all the stuff that's not related to the actual procedure code for what you're trying to do is in many cases more important for us in terms of how we take better care of people. So my opinion, which is what you asked for, is that I actually think in some ways we've gotten the conversation wrong. I'm not saying that everything that's on the table right now isn't necessary. And I'm not saying it wasn't the right place to start, because I actually do think it was. You start with what you can do. But I don't think it's the right way of thinking about the problem, because I think we have to start upstream and get better at exchanging all the stuff that I now have to deal with every day if we actually want to solve the intent that was based in all the discussions that have been had over the last 5 years. And I know I've flipped it on its head. In some ways, I changed the question on you. My apologies for that. But I really do feel very strongly that we have to start with where you meet the patient, take care of them, and then the rest comes from that.
Yeah, I actually talked about the clinical world. You've got maybe not so much data, but it's very deep about a payer, about a patient. The payers have a very broad view of the patient, but not very deep. I actually talk about the payers' claims history being the connective tissue of the care journey. And I think we're at this point where you can start to, when we start to see directories dropping into place that you can find digital endpoints, increasingly you'll be able to navigate to say, oh, so somebody went for care there. Now, can I go and actually get access to their clinical data in that location? It just provides the clues as to where to go. But Kevin, we've kept you quiet for a little while, and I know you've been talking to a lot of folks in the Medicare Advantage and the Medicaid space. You know, how are you seeing those payers looking at the challenges and the opportunities with the with this interoperability rule?
Yeah, I think they see a lot of opportunities. You know, just getting all this granular information to understand the whole picture, to understand you know, what's going on with their consumers, what's happened to the consumers in the past, to understand their health history as they're coming on board to the health plan. I think that's really big. And I think that they really want to collaborate even smarter with their providers. So I come from a background in integrated care. And for example, a lot of patients that experience serious mental illness, the providers that are responsible for taking care of them and not only making sure that their well-being is looked at, but also the cost of care. They're dealing with a lot of information in silos, and they're unable to access key information that's going to keep them out of the hospital. So when we can start interacting better, when we can start sharing this information in near real time, what we're going to do is help consumers, especially those who are, like I said, high risk. We're going to help the providers get access to information that's going to adjust the care plans, that's going to inform the clinical pathways, that are going to inform clinical pharmacists so they can understand consumers that are taking several medications, even up to 12, 14, 16 medications. I think when we have this information exchange, we're going to really be able to not only save lives, but we're going to be able to fundamentally change lives of patients. Like I said, especially those with multiple comorbid conditions, those with serious illness. So I think the payers are excited about the opportunities of exchanging information.
Yeah, I think there's some interesting opportunities. One of the implementation guides I've been involved with is called Payer Coverage Decision Exchange. And if you think about one of CMS's aims is patients over paperwork. The idea of being able to, when a consumer moves from one health plan to another, which may be not their choice, but maybe their employer, for example, moves them. And if you're on some sort of preventative program that probably you've had to sit down with your provider and go through filling out justifications to submit to the health plan to get put onto those, and then you suddenly move to a new health plan and you're starting from zero and you've got to go through that again. It's crazy. And so payer coverage decision exchange is really about one plan being able to ask another, does my member have, a care plan in place, and how did you arrive at that decision, so that potentially it can streamline the process and not require the member and the provider to sit down and redo all of that justification just because it's a new insurance plan. I think these are the things that we'll see coming out of things like the Da Vinci program, where payers and providers get together to solve these pain points. These, I think, are the real opportunities. Now, I'm going to do a time check. And Rebecca, I think you've been popping some questions. Some of us will have to drop at the top of the hour. I know, Klaus, I think you have to drop at the top of the hour. We are happy to go on longer, but I think it's really, we'd love to see questions from the audience. So please pop them in the chat so that we can respond to them. Otherwise, we'll be calling a close in the next couple of minutes. So Klaus, I know since you, I think, have to go at the top of the hour, are there any final comments that you have about really what we're looking at in the next year or two with both the opportunities and the challenges?
I think it was Kevin who used the phrase real time. I think that's important. And so I think we'll see more data sources of relevance. They will be more diverse. You'll get more and more information, not from traditional sources, think wearables, smart devices. I think the key is near real time. If we actually want to make a difference in how we take care of people and not just how we bill for it afterwards, it has to be real-time access. And to your own point, Mark, it has to be orchestrated. Where and how that orchestration happens, we've got choices. But unless we get to near real time, I think we failed the mission to improve care.
I think that's a really important point, Klaus. One of the things that I think was the piece that was glossed over by a lot of folks reading the interoperability rule was basically saying payers have got to release the data within one business day of adjudicating the claims. In many cases, that's taking the industry from working on a month, 30-day basis to daily. That's closer to real time. And if you think from the consumer perspective that if I'm suddenly diagnosed with cancer, 30 days can be a death sentence. Mm-hmm. Yeah. And the ability to get your data within a day potentially and start to pull that information together could be the difference between life and death in some cases. And that's probably an extreme example, but that's going to be I think one of the things that is going to be an unintended consequence of this rule is the shift in the industry closer and closer to real time. So Bill, any thoughts from you?
Sorry about that, on mute. So, everybody would be working on this on their own time frame if it weren't for the rule. Obviously, the closer you can get to real time, the better off you're going to be for from everybody. And the interesting thing, again, if I take the consumer perspective, consumers already expect and anticipate that we are all joined at the hip to begin with. We know the truth of that inside the industry, dirty little secret, but consumers already expect that we already have access to and know everything. You know, again, the closer we can get to it, the better off we're going to be.
Yeah. So we actually do have a question in. I know, I think Klaus has had to go, but those of us that can stay on, says a couple of things we've encountered during testing and validation of fire apps to support provider to provider and provider to payer exchange are this: technology vendors are that very few providers have fire endpoints available, and very few technology vendors are interested in participating in the kinds of testing, validation activities that help support viable app development, mostly because neither the vendor nor the provider is incentivized to do that work. How do we address those issues? If you want, I'll take a first shot at this to help folks out there. That actually part of the rule is that health plans do have to test their APIs. So there is one of the things to be aware of in the fire community, and I would say there is a fire patient access education event coming up on the 27th to the 29th by HL7 that is really a great place to get a lot of questions answered. It's well worth looking up. But HL7, all of their implementation guides expect validation tests. So there are tests being developed. All of the Da Vinci implementation guides, which largely CMS points to, all have both reference implementations and that are open source, and have a set of validation tests run by a testing organization that's contracted by HL7. And I think there is a movement going on around the industry at the moment to establish a more formal certification program for, certainly for consumer apps. And all of that, I think, will go to addressing this issue of, you know, is your API compliant, but also increasing confidence for consumers and basically API data holders as well. Bill, Kevin, any thoughts on this?
As a matter of fact, I have a meeting on my calendar immediately after this to discuss our testing protocols. One of our architects that has been working very closely on this has been absolutely adamant that we get testing people in place as soon as possible to both develop the protocols, and then as soon as some of the early infrastructure is in place to begin working on making sure that it is fully operable. So from that standpoint, I would say, you know, we are very focused on it. Likewise, I go back to my earlier statement about trust and consumer trust. If we're not delivering on the promise, either to consumers or to providers, our credibility goes down pretty fast. And that's one of the most important things that we have in the marketplace. So we take that very seriously in terms of making sure everything is and will be thoroughly vetted and operable.
Yeah, one of the things in the fire specification itself is is actually called the fire validator, which you can validate the data you're trying to load into the fire server. And so our ingestion protocols with our Sapphire platform put data through those validators to make sure that they're compliant with the relevant profiles. I mean, that's a very basic step that really anybody can do that's dealing with either adding data to servers or pulling data out of them. But I think that we need to move to more comprehensive testing, and I think that will come as we learn as a community. Kevin, any insights from your side?
No, I guess the only thing I would say is, yeah, that testing is a key piece. I think documentation is also critical, that you're sharing the documentation with the app developers, making sure that they're on the same page as you are as far as what they're going to need to know to interact with your data. And I think testing is just something that anyone from an IT perspective is something that's going to be top of mind. So I agree with what you both said.
Yeah, so let's see, we have a few other questions coming in. This is all good. Question, given all the positive reasons to integrate, why haven't we yet? I think that may just be a case of maturity of the standards. The reason we, I was fortunate with Blue Button that the EMR vendors were getting together and developing the Argonaut API. And so that was giving some kickstart to Fire, and we therefore leveraged that, recognizing this is probably the direction the industry was going in. So feel free, free for all, if anyone wants to comment on any of these. There's a question in the audience.
Yeah, Mark, I think the answer is very simple. We haven't had our feet held to the fire yet, pun intended.
Yeah.
But no, in all seriousness, organizations are not going to do something unless it's in their interest.
Yeah.
And so, and particularly in a very competitive industry, cross-platform, cross-organization integration, that's a tough one to bite off.
Yeah. I think it's an issue where, yes, unless you're going to benefit, and that sort of goes to this idea. Up to now, we've treated information as an asset that is more, better when held close to our chests. But now there's so much data flowing around, it becomes more and more important. And as you shift to value-based care programs like that, it starts to now make an impact. For a provider will look and say, well, oh, there was an X-ray done down the street only a month ago. Do I really need to do another X-ray? Because now it comes out of their bottom line if it's based on effectively a capitated model. So it's this combination of everything that's going on that really has an impact. There was, I think, a question for you, Kevin.
Yeah.
In your market research, did you get a sense for whether payers will prefer to build in-house versus partner with vendors to build these new systems? What do you think factors will influence? I think time's a factor, isn't it?
Right. A lot to share there. So what I've learned is that some of the payers, they look really closely at their staff, at how much capability they have. I've interacted with some payers that are kind of in a remote part of Wisconsin where it's really, tough to get the resources. But then at the same token, I've found some health plans that have done a bang up job of attracting talent. So they feel confidence that they can develop these tools themselves. I think another huge factor is what vendors have they already started working with? Have they developed solutions in-house before? Or have they, gone with vendors that are offering solutions, for the interoperability? I think that's a big determining factor. Cost is also a huge factor. Not all health plans are built as, some of them are pretty well situated on the cash position. Other plans are really kind of struggling where they're at right now. So they're going to be trying to maybe go outside and maybe look at a whole host of different options to keep their costs down low. And then the only other thing I would say is, what are some of the determining factors? It would be, how confident are they to, work in the cloud? Sometimes the plans are looking at have worked previously on on-prem solutions, but if they want to get in the cloud, they might be better off working with a vendor who's been doing it for years and has figured this out and how it's all going to work together. Maybe like a platform as a service solution, much like what the good folks at Onyx do. So I think those are some of the factors that they consider.
One of the things I would add to this is people also need to think about the standards themselves and where are you best to focus your resources as an organization. What we have to realize is that the guides that CMS is pointing to as ways to comply with their rule are in the very early stages of publication. In some cases, we're waiting for the first official publication. Those specifications are going to change. The fire specification itself is going to change. It is going to go from release 4 to release 5 at some time in the next probably 18 months. When those things happen, that's going to have a knock-on impact. Any changes to an implementation guide when release 5 is in play is going to mean a change to support that guide. So if you've taken on all of the implementation responsibilities, or even parts of that, every time those different implementation guides changes, you're going to have to think about the data, the access methods, the authorizations, and so forth that you need to now then revisit. And so you also should be making a judgment on, is that something you're better to hand off to a service provider, and you focus on the value add to you as a business, and let them deal with the mechanics of, oh, we've got a new version of this implementation guide. You know, those I think are also things to take into account, particularly when there's how many 8 months left to be able to really have this system in place. So let's see. I think we have a couple more questions. Let's see. Within the provider industry, the health system that compel them mostly going to implement only when there's no scope left to delay the interoperability. Do you think providers have already started with their movement towards this vision of data sharing? Where do they currently stand in this roadmap? What are the options providers are considering as an implementation partner for this change? I don't know if you folks have got unfortunately, Klaus had to drop. I think the situation with the EMR vendors, obviously they were early in this process, and their Argonaut compliant API is really based on the version 2 of FHIR, known as DSTU2. They, I think, are on a program over about the next 18 months to get recertified, to get to the same version of R4 as the payers are on. And that will obviously also expand the amount of data that is being exchanged. I think there is some interesting stuff in the ONC side of the rule around information blocking that's going to force more openness. And there's also, I think, a provision in there that if you are there as a provider, you have a certified EMR, that you can integrate your own applications into the FHIR APIs without necessarily having to pay the entry tax that these EMR vendors impose on other applications. And that starts to raise some really interesting opportunities where providers are looking at how they maybe partner with payers and other business partners. There get to be some really interesting things. I always find it fascinating to listen to Anish Chopra, who was the first CTO of the USA, and he's very active in all this space, and how he connects some of the dots in these various regulations and what that might mean. So I think we're going to see a big acceleration in what providers are able to accomplish. Bill, I don't know if you're seeing anything from your side on with interactions with providers.
Yeah, on a limited, I have limited visibility to that.
Yeah.
But but I would go back to what's going to drive that. What's going to drive it is very clearly the ability for providers to deliver greater benefit to their patients. And to the extent, and I'm sure most if not all providers, again, they can see the benefit that's going to exist. So for them to continue to adapt, stay connected, and gain more connectivity and greater access to the data is going to be in their benefit.
Yeah. So one of the things people should consider is some of the sort of background to the CMS rule. And obviously the initial push for the APIs with EMR vendors really came from the ONC, and that led to meaningful use, the 2015 certification. That really embedded that early version of FHIR APIs, the Argonaut APIs. But that's been really required the federal government to try and strong arm the EMR vendors to provide these capabilities. Part of, I think, what is happening with the CMS rule and its accompanying ONC information blocking rule is really about payers are now going to have an incentive, I think, to talk with their providers. And so I can see parts of contract negotiations being, what APIs are you going to open up to me, right? And that then becoming the part to help data flow, again, driving things like value-based care. That in turn is now going to put providers knocking on the door of the EMR vendors saying, I want these APIs. And so instead of just the CMS or the ONC trying to persuade these EMR vendors to comply with providing APIs, instead you'll have the market as a whole starting to push them to do what it is. And if they want to keep their market share, they're going to have to respond. I think that's sort of the part of the reality that CMS was trying to create. So it's an interesting perspective on really where we're heading. I see that we're 15 minutes past the hour. I certainly I think we're probably at a point that we can think about wrapping up. I hope this has been useful to people. As you see, we had a good few questions come in. Rebecca, were there any final questions that we should be addressing, or should we be bringing this to a close?
You have answered all of our audience questions, so I believe we're good to collect final thoughts and close out for the afternoon.
Okay, so Bill, how about a few final thoughts from you? You're still on mute.
You would think I'd learn by now. I go back to where I started with my comments, which is there's absolute benefit in this long term. The journey, the road is a little challenging, as we've discussed. There are a lot of roadblocks to it. There are a lot of bumps in the road. But I am very excited to see this coming down ultimately as a mandate. Ideally, you'd want to see it having gone through as more of a consumer-driven or a business-driven desire. Not the case. So it's here now. We are certainly moving full speed ahead, not just with things for the mandate, but obviously looking down the road in the future to how we're going to be able to leverage all of that data in the future. So I'm very excited about the potential, and I think most insurers would agree that there's a tremendous opportunity here to serve our customers long term. And ultimately, that's what we're in business for, is serving the people that pay us to do that.
So, Kevin, what are your thoughts?
Yeah, I think that this is a tremendous opportunity. I think we have to do a really good job of getting patients to rethink data and information. I think we need to make sure that the patients know the what's in it for me. And when we share information, when we exchange things back and forth between payer and member, or patient and provider, I think we need to do that with that in mind. And we have to really make sure that there's a dialogue going on, that patients see that sharing information is a way for them to be healthier, for them to get the best care, for them to get lower costs, less out-of-pocket costs by making the right decisions using this new data. So if we can do that, I think that interoperability is going to be huge. And lastly, I'd say back to the value-based contracting, I think when providers have more near real-time information, and then I can actually see how they're performing against the parameters of the contract, I think when we can do that, providers and payers are going to be able to get into several more engagements, and those are going to be more successful, where payers and purchasers can really buy value, and providers can feel a lot of trust in getting into those relationships because of the better access to information that affects their bottom line. So that's what I would say.
Yeah, and my final thoughts really are that consumer trust is really job one. It doesn't matter whether you're payer, provider, or anybody else in this healthcare industry. Consumers are going to choose who they trust. That's who they'll share the most data with. If you think about CMS, the release of Blue Button was picked up by beneficiaries. Actually, Blue Button last year powered the Medicare coverage tool and that was the most popular site on the federal government site on the internet last year. So it was being put to use by beneficiaries because it brought value to them. So people will use the information when it is of value, but they don't want the information for its own sake. They want to put it to use, whether it's for themselves or to help others. And that's what we have to think about is helping this basically happen. And CMS is really taking this crawl, walk, run approach. So next year, 2021 is really about kicking the tires, seeing your infrastructure works, letting consumers have access to their data. But the real flow is going to start coming in 2022 with things like payer-to-payer exchange, where payers will be able to, when they're enrolling members, saying, do you want to give us your prior coverage information and we'll go and get your health record? That comes back to trust being job one. And now they have more data. The question is, how are you going to make use of it? This is what you need to be planning for in 2021, for how you're really going to leverage this increasing flow of data in 2022. It's going to be a fascinating few years. And this is really just the start. This is not the end point. If you go into thinking about this as just a compliance exercise, and that's all you're going to do, then you are missing probably 90% of the potential value that is out there from this. This is really going to change the industry and drive it to become more consumer-facing focused. So with that, I'd like to thank everyone. Klaus obviously had to leave us earlier, but Bill, thank you for your insights. Kevin, thank you for yours. It's been a pleasure to be part of this. I would be happy to come back and do this again. So thanks, everyone. Have a great rest of your day. Thank you.
Thank you.
Thanks.
Thank you, Mark, Kevin, and Bill, and Klaus for joining us today. Thank you, Bobby and Medical Alley Association for partnering with us on this event. And thank you to all of our members for attending. Please look for future webinar events on our website at mn.himschapter.org. Thank you.